My original title was Forecasting in Myotonic Dystrophy. And why did I choose the word forecasting? I think that it's something that we all do. It's something that we do in our lives, in our health. And it's actually a lot of what doctors do. We just sit and think, I wonder what's going to happen, right? So here are some questions. Will the Dodgers win the World Series again this year? I'm from Los Angeles. How do you think about this question? What are the odds that will happen? And will our president complete another 4-year term? Is that going to happen? And lastly, if you look out 50 years, will our oceans warm by 1 degree Celsius? And these are hard questions, right? These are forecasting questions. And if you think about it, they're hard for a reason. No one has this crystal ball, but there was this researcher named Philip Tetlock who did a really interesting experiment. He gathered these political and economic experts. And he said, how good are they at predicting what's going to happen? And so he took these 284 professionals and he asked them thousands of questions. And the results were published in a major journal because it was like guessing. It was like pure guessing. And that's why the picture of the chimpanzee and the dartboard, like blind guessing. And Tetlock explains it. The experts are just human in the end. They're dazzled by their own brilliance and hate to be wrong. Experts are led astray not by what they believe, but how they think. And the punchline was not really that everybody was really bad at forecasting, because there was a small group of experts that were just a little better. And it was noticeable. And actually, this is what caught his attention. It wasn't that everybody was terrible. There was a small group that was just a little less terrible. So he decided to try to find out what made these people a little better. And that was really the subject of this project called the Good Judgment Project. Now, this was actually funded by DARPA. So this is our defense. This is like the government got a hold of this, How can we predict better? So what he did is he actually looked for people like us in the community who were really into trying to predict political events. And he found them. He found random people, housewives, computer software engineers, who just were really good at predicting what was going to happen. And he wrote a book about it. In fact, he actually government sponsored tournaments. So there was a tournament with his team of lay people. The government had a team. I think Cal had a team. The Ivy League had a team. And there was multiple teams. And like for 4 years in a row, his team of lay people like blew everybody away. And I read this book when it first got published. It's really influenced how I practice medicine. And what the book does is it takes, this is just what I just said. Most people are terrible at predicting the future, but a small subset of people are significantly less terrible. These are the super forecasters, is what he called them. So the book is really about what makes a super forecaster, right? And how do these people actually think? Not what they believe, but how do they think? And so each chapter is devoted to what is a feature of a super forecaster. But number one, they can't be very dogmatic. They have to be open-minded. They have to be willing to change their minds, right? They're not necessarily like the smartest person in the room. You have to be smart, just smart enough, right? They analyze problems from the outside view first, and then the inside view, right? So an example that would be the Dodgers. One might ask, how long has baseball been played? How many times have teams won back-to-back titles? That's the outside view. You got a base rate. And then the inside view would be, what are the injuries on the Dodgers right now? What is the inside view? Like you take the broad and then you go in, right? A lot of times we want to start in and then forget about just base rates. And so they think in this way. They have a growth mindset. They don't feel like, oh, I can never get better at this. They really feel like I can get better if I just put more thought and really borrow ideas from other people. And importantly, they know the difference between luck and skill. So they know when they got a question right versus wrong, and where they just got lucky, right? They thought it was going to happen for one reason, but they got it right for totally different. And on the right is a kind of a modified graph of one of the early chapters, showing that they update their beliefs more often and in smaller increments. Okay, what is this graph? So the way the tournament works is a question is posed. This question happened to be, will the number of refugees reach 1 million by spring or something like that? That was the question. It opened in January, and the question opens, and each dot is a forecast by the lead forecaster for the year. He's a computer scientist in Vancouver or something like that. And the question is going to close in June or something like that. And so you have time to change your mind. And you can see that not a lot of confidence in the beginning. And he's looking at data. He's actually looking at countries' data to see how many refugees are coming into each country. And by the time March comes around, he's very confident they're going to reach 1 million. And so that means that he's updating his beliefs. He's looking at data. He's really thinking through, like, where is this going? Lastly, they put super forecasters together and they helped each other get even better. So they work well in teams. They are listening to each other. And so there's a lot of parallels in medicine. And I think also just in myotonic dystrophy and how you make predictions. So how do we think about, I'm a cardiologist. I'm definitely not, I think most of you way more than me about myotonic dystrophy. I do see a lot of patients with muscular dystrophy. I'm blessed that way. But really, the real experts are the neurologists and the neuromuscular specialists. I get to take care of your hearts. So I'm really grateful for that. But what do we do to forecast about your hearts? First, we just take a history. Right? We might ask you, have you fainted? Have you been having palpitations? Are you short of breath when you lie down? And we ask questions to try to inform our predictions, right? And then we do an exam and we listen to just how does a heart sound? Does it sound congested? Does it sound extra slow? Does it sound too fast? Are the valves working well? And then we have a bunch of tools. There's EKGs and echoes and MRIs. And lastly, we just try to keep an open mind about what's happened since the last visit. That's why we always update. Has anything new happened, right? So we're always thinking about predicting, like, what is going to happen in the future. And then lastly, as we work as a team, we're always calling one another. I think you guys are the star of the team. You guys really have the most insight into what might be going on just by sharing your story. And as they say, that the history is probably 80% of the diagnosis, just taking a good history. I do think that the book, if you're interested in, I think it's relevant to every walk of life. It happens to be one of my favorites. Okay. I'm going to talk about 4 key areas of cardiac involvement in myotonic dystrophy. We're going to talk about the conduction system. We're going to talk about rhythm abnormalities, cardiomyopathy, or the heart getting weaker, and lastly, coronary disease. Okay. So let's start with just the conduction system. And this is just a cartoon that hopefully will keep it very simple, but it's powerful because it's a beautiful system that is the same in all of us, but gets a little frayed in myotonic dystrophy. So starting in the upper left, where it says sinoatrial node or SA node, that is your body's natural pacemaker, right? We all have one. Some of us might beat a little faster or slower, but it's all driven by that natural pacemaker up there in the upper, I guess it's the upper right side of the heart, right atrium. And it's the pacemaker because it leads the way. It's kind of like a pace setter in a marathon. It's leading the way and it's telling the heart how fast to go. And impulses go, we'll think of them as electrical impulses that get splay over both of the top chambers called the atria, but they converge right in the center in that atrioventricular node, the AV node. Okay. Now, why is it important that we have an AV node? It's a gatekeeper. Just do the thought experiment. What about if you end up with a rhythm in your top chambers that's going 300 beats a minute, right? If you didn't have a gatekeeper, you would collapse because your heart going 300 beats per minute, it's just not good. You need something to tap the brakes, right? So the AV node is really important to put the brakes on what's happening above. And then once the impulse gets transmitted through the AV node, it goes into this section called the His bundle. And that's just south of the AV node. There's a reason why I'm going slow, guys. This is like the heart of what's going on in your heart. This is really important. So I just want to take some time with this. The His bundle then conducts 2 bundles, a left bundle and a right bundle. And in a very organized way, the right and left ventricle contract together. And then the cycle starts again. Yeah, another beat, and the same thing happens over and over again. In myotonic dystrophy, there can be progressive slowing in this conduction system, right? So the question that we often are asked is, how do you know if you need a pacemaker? When is it time? And I think this is one of the areas that really sets myotonic dystrophy apart from any other condition, right? It's its own unique condition that if you're not in tune with it, you will miss something that seems benign. Let me explain. Okay, so on the right, I guess on your left, let's just go through these different EKG strips, because these electrical activities, they show up as an EKG, right? This is how we're actually measuring how slow or how fast these impulses are going through the heart. So normal sinus rhythm is up on top, which patients with myotonic dystrophy will usually be in this normal sinus rhythm. The little bump is the activation through the top chambers called the atria, right? Then there's a pause as it gets through the AV node, and then there's a big spike as it gets to the ventricle, right? That's really what you're seeing. The ventricles are big, so it's a bigger spike, right? The atria are smaller, so it's a smaller spike. It's all there is to it. And then the little bump afterwards is just the heart repolarizing or just getting ready to do the next one. And then the cycle starts over again. And so this rhythm strip here just below it is called first degree atrioventricular block. And what do you notice? The delay between the little bump and the big spike is just longer. And it shouldn't be more than 200 milliseconds. All right, that's the upper limits of normal. And once it gets longer, like 240 milliseconds in myotonic dystrophy, you're actually starting to think about pacemakers. No other condition is like that. We do not put pacemakers and defibrillators into people for long PR intervals, except in myotonic, to my knowledge anyway. I could be correct. Someone can correct me, but to my knowledge, this is the only condition where we take this really seriously. So I always say, you should know your PR. Not personal record, but you should know what your PR interval is. And you should ask your cardiologist, what's my PR interval this year? Good thing to know. There's also importance in how wide the spike is, the big QRS complex, because that once it starts getting above 120, right, that's called a bundle branch block or some sort of delay. And that can be a marker. Maybe it's time for a pacemaker, right? A screening lead, a 12-lead EKG is recommended for patients with myotonic dystrophy. Depending on age and the results, we may actually request that an annual EKG be done. And I write here, so if it's more than 240 milliseconds, or if the QRS is more than 120 milliseconds, this may warrant a pacemaker or maybe an electrophysiologic study. We're going to talk about an EPS or electrophysiologic study in a second. But just to round out what's on the bottom here, these are more advanced forms of heart block where it's just the degree of blockage at that AV node, and HIS is what we're talking about here. Just how blocked is it? In this case, with the second degree AV block, Mobitz type 2, there's this sudden drop. You can see there's a small bump, big spike, small bump, big spike. And then all of a sudden, there's just a drop of a spike. Conduction didn't make it down to the ventricles. That's what happened. It stopped. And when you see a sudden drop like that, can be a marker of fraying of the HIS bundle or below the HIS bundle. We call it infraHISian. And this is different variations. The most extreme is third degree block, which is there's just no association between the two. The top chambers are doing their thing and the bottom chambers are doing their thing. That's complete heart block. And really these are automatic pacemakers, really for anybody, pretty much whether you have myotonic dystrophy. What makes myotonic dystrophy a little different is you have to take just the first degree AV block pretty seriously. Okay, what is an electrophysiology study? Some of you may have had one. So let's just talk in a little bit more detail about what it is. This is, again, working as a team. If I was a little worried about the PR interval, say it was borderline, maybe there's some fainting, can't tell. The PR interval is maybe 220, and I'm worried that there's fraying, I can ask my colleague in electrophysiology just to test out and stress the system. How good is it? And what they do is they put catheters in the heart. One is in orange, one is in blue, one is in green there, right? And what they're doing is they're just measuring how much time the electricity takes to pass, right? And one of the key things that you cannot get on an EKG that you can get during an there's a couple of big things. One is something called an HV interval. H stands for HIS bundle. V stands for ventricle, right? HV. So it's all really pretty straightforward. How much time between the time that you see the HIS bundle activate and the time that it reaches the ventricle. And the reason that's important is because if the block is in the AV node, it's less dangerous than if the block is underneath the AV node. If it's underneath in the His bundle, more dangerous, right? So you're actually measuring that HV, and normal is about 30 to 55. And if you're getting above 70, that's considered abnormal. And you might take that maybe episode of fainting or that slightly up here, we might take that more seriously, and it might nudge us to recommend a pacemaker or a defibrillator. The other thing that the electrophysiologist is doing is sometimes they will actually ask, how prone is your heart to develop ventricular arrhythmia? So again, there's atria and ventricles. Arrhythmias can happen in either place. So they may actually tickle the heart just to say, can I put you into a worrisome rhythm really easily, or is it really hard to put you in? Maybe, and so that's the technicalities are not important, but it's just asking, can we cause worrisome rhythms in the ventricles? And if it's negative, sometimes that's reassuring. If it's really positive, like, boy, one little tickle and it goes into ventricular arrhythmia, it may nudge the team to move towards a defibrillator instead of a pacemaker. Again, defibrillator gives you shocks, pacemaker just pacing. So those are some details on the EP study and why you might do one. You don't always need one. If the EKG is really obvious, PR interval is really long, QRS is really wide, then you don't need an EP study. You probably just need a pacemaker. Okay. So speaking of pacemakers, there's lots of different types out there. I think that this is important because just many of us like new toys, and sometimes the new toys haven't been as studied in certain conditions. This is, as you can see, there's 3 leads. There's a generator over there on the right, and the 3 leads are coming into the heart. The first one is pacing the atrium. Lead number 3 is actually pacing the ventricle, and this is a defibrillator because actually it has that big thick coil at the bottom. And lead 2 is actually pacing the left ventricle. So this person probably has a very wide QRS and it's trying to resynchronize the heart. So this is called CRTD, or cardiac resynchronization therapy. D stands for defibrillator. And the reason why you would want pacing above and below is because I said, remember, the AV node can get weak. So you want the 2 chambers to talk to each other above and below. Otherwise, if you just put a lead in position number 1, those impulses can't get past the AV node, right? If you just put the leads down below, again, they don't communicate very well. So this is a way to take over the conduction system. And I put some numbers there that you can just look at for your own reference. So if your QRS is very wide, our third lead might be recommended, like 150 milliseconds is a number. And then you might say, what's the base rate? Talking about base rates, how often are people getting pacemakers and defibrillators? And the answer is it varies. The literature does vary between single digits to 20%. And in one study where they did electrophysiology studies, I think it was up to 40%. So what's too much, right? This is like I think sometimes it's a hard question, right? But this is why sometimes we bring you back for another EKG just to see if there changes. That's why we sometimes send you home with monitors, right? To keep an eye out. Speaking of that, when you go home with a monitor like a Holter or a Zeopatch, we're looking for arrhythmias, right? This is not just a 12-lead EKG where you're just asking in a static one time. We're actually asking over the course of days, sometimes weeks, and sometimes years, are you having any scary pauses? Rhythms that can be seen with this are typical and atypical atrial flutter. We'll talk about that in a little bit. Atrial fibrillation. Supraventricular tachycardia is where the heart's just speeding up in the upper chambers. And then it's important to know that sometimes the heart is the first thing that presents the first symptoms before the muscle presentations, the skeletal muscle presentations. Ventricular tachycardia, which is fast rhythms from the bottom chambers. And monitoring is not like one size fits all. If you're young and your EKG is perfect and your echo is perfect, you probably don't need to have a loop recorder every year. But as we get older and the EKG changes, you might need monitoring every year. And if we're really worried, we can use what's called a loop recorder. We may say we're worried but not ready to commit to a device. We can just put in a little paperclip thing underneath the skin and it can monitor you for 3 to 4 years and is looking for heart block, arrhythmias, things that are going to change our management and for recommendations. So I want to spend a moment just talking about atrial fibrillation because it is a common rhythm. It's common in the general community, and it's common in myotonic dystrophy, maybe slightly more common, but not vastly more. And what is it? We talked about this organized rhythm that comes from the sinus node. Atrial fibrillation is the opposite of organized. It's like chaos. You can see on the right there, it's the atrial are just quivering and going at a 500, 600 beats per minute. It's not really organized, not even beats. And again, the AV node keeps everything in check, keeps it from going 300 to 400 beats per minute. But it's quivering in such a way that clots can form. And that's why sometimes you'll hear that people with atrial fibrillation have to be on blood thinners. And then you have Kareem Abdul-Jabbar advertising Xarelto or Eliquiz, I forget which one he advertises. And so it's a very common rhythm, right? Yeah, so it's, and you might say, can I control this? You have some say over it. So if you have sleep apnea, treat it, right? It's actually one of the triggers for atrial fibrillation. Limit your alcohol. It's another trigger for atrial fibrillation. And then in terms of blood thinners, not everybody has to be on blood thinners, but it's about your risk profile. So if you have high blood pressure, if you have diabetes, those increase your risk. So those are things that sometimes you can control. Unfortunately, we can't control our age. Gender used to be in this formula, but they actually just removed it. It's a little different now. But be that as it may, if you have 2 points, usually we're recommending blood thinners if it's safe to do. Many of you, you've had imaging of your heart, and the most common one is an ultrasound called an echocardiogram. And it's common because it's really available and it's really simple and effective. And it tells us what's called an ejection fraction. You guys have probably heard that. So when the heart pumps, not all the blood leaves the heart. Normal is about 50 to 70%, 55 to 65%, 50 being the low end of normal. And so you might hear my ejection fraction is 55%. That's actually great. It's normal, right? But in a more elegant way to look at it is MRI, but sometimes you have to do breath holds. That can be difficult for some patients with myotonic dystrophy. So I don't know, it does add the amount of scar that you have in your heart. So that's useful in some cases, but it's not something that we would do every year or even every other year. I think it's just, if it changes our management, we would get it. Cardiomyopathy is when the heart starts getting weaker, right? At least in my experience and in the literature, you might hear up to 40% develop LV dysfunction. That sounds scary. In practice, honestly, that's not a big feature for myotonic dystrophy. Now, I'm not saying that we don't see it. I'm not saying that it won't happen, but it's not like the conduction issues. The conduction issues, I think, is the Achilles heel. That's one that you really have to be aware of. And the reason we're doing echocardiograms is because our medicines are really good at strengthening the heart if we catch things early, right? So in other forms of muscular dystrophy, like Duchenne or Becker's, if the ejection fraction gets down to 50%, right, from 55 to 50, we're starting medicines, right? Because by starting it early, we can keep the heart strong. We really practice the same way in myotonic dystrophy because we don't want the heart to go down to 45, 30, 30, 25, because we have good medicines that can arrest that in most cases. This is the reason why we're looking. Again, it's not something that you have to do every year, but as you get older, you might do it a little more frequently. Sometimes blood pressure can be a little bit lower, and some of the medicines that we like to use aren't good ideas, like beta blockers, right? Love beta blockers for cardiomyopathy, but because they slow the heart rate down, you get a little shy with them, maybe try to avoid them. But then once you have a pacemaker or a defibrillator, take all the beta blockers you want because you have a pacemaker. So you can focus on strengthening the heart. If your ejection fraction gets below 35% and you've tried medicines, that's usually where the doctors will be nudged to offer a defibrillator. But I don't want to say controversial, but it's complex. You don't have to have an ejection less than 35% to get a defibrillator. There's a lot of discussion that goes on if I'm getting a pacemaker, maybe I should just get a defibrillator. Maybe it depends on the electrophysiology study. Maybe it depends on the EKG and how wide the QRS is. It's not a one size fits all. And so I think that's something that you should just really discuss in detail with your cardiologist. Okay. Coronary disease. Why are you talking about coronary disease? Because it's common and most of us are going to have to deal with this, right? So what is it? You've all heard of plaquing in the heart, right? And why you watch your good cholesterol and your bad cholesterol. What I want you to take away from this picture on the right is just what is it? What exactly is a plaque, right? On the very far, you see that thing that looks like a pipe, right? That actually has 3 layers. The inner layer is one cell layer thick. It's called the endothelium. Next to the endothelium is that big thick layer, which is really smooth muscle cells, and that's the media. And on the outside is the adventitia. So there's 3 layers in that thing that looks like a pipe. And the reason why we want patients not to smoke, the reason we want patients to control their blood pressure, we don't want diabetes, or we want to control all these risk factors, is because this molecule called LDL, the quote unquote bad cholesterol, gets modified. It gets oxidized. It's happening. And so when you have a lot of stressors on it, it gets modified. And when it gets modified, it gets sticky. So when it starts getting in between the inner layer and the middle layer. So that plaque is really between the inner layer, the endothelium, and the media. And you can see it's a big lake of like fat and cells. And it builds up from early on, from our teens. And so the best thing to do is just try to avoid it and try to eat clean and control all the risk factors. So how might it manifest? You might have some chest pressure when you walk. You might have jaw pain, things like that. Why is that happening? The heart is a muscle, right? The heart's pumping, and these arteries are what's supplying the heart with oxygen, right? And so if there's a blockage and part of your heart isn't getting enough blood supply, it tells you, it gives you a clue like, hey, I'm starving for blood here. So that's what angina is. And this can be fixed either with bypass surgery or with a stent, right? If it need be. But again, it's always best to try to prevent it in the first place. Okay, so the recommendations for coronary disease are really not different for myotonic dystrophy in the general population. So limit your risk factors as much as possible. And remember that if your exertion is limited, angina might not manifest, because if you're not running up a hill, then you might not see it as fast. So you have to be really in tune with your body, because it might be subtle, like more shortness of breath or just subtle chest pain that you think is indigestion. Statins. Now, you guys have probably heard of statins. Some of you might be on it. Statins are probably the gold standard for lowering LDL. I worry about using big doses of statins in my patients with myotonic dystrophy because it can cause muscle aches. And so I'd much rather use tiny doses to accomplish the goal. And what I've found is that if you eat really clean and use a small dose of a statin, it works a lot better than if you eat like garbage and use a small dose of statin. It actually really works together. But we're not afraid to use statins. Most patients will tolerate it just fine. But the good news is there's lots of other tools out there that are not statins that lower the LDL really well. It's just that the statins really I would say have the most data for prevention. So I don't think you should automatically exclude them if you have coronary disease. I should say, this is not on the slide, but you guys might have heard of lipoprotein A, Lp(a). That's something that you might want to check with your general doctor or with your cardiologist, because it is a new driver. It's a newly recognized driver for atherosclerosis that is not modifiable very well at all by statins. And unfortunately, diet doesn't really affect it as well as we'd like. So the tools are coming probably in the next year or two to lower Lp(a). But so if you happen to have coronary disease and very high Lp(a), that would be something to, again, keep an eye out for. Stress tests, right? So that's how you usually screen for coronary disease. That picks up advanced plaques, like 70%, 80%, 90%, 100% blockages. That's what stress tests pick up. It doesn't pick up the lower ones, the ones that are 50%, because it's not leading to enough of a supply and demand mismatch. But there's other direct ways to look at the arteries, right? Stress tests are indirect. We're not looking at the arteries. We're just indirectly trying to assess what's happening in the arteries. But you may have had a calcium score, for example. That's actually looking at the arteries and saying, how much plaque buildup do I have in terms of calcium scores? And it tells you relative to your peers, where are you? And then CT coronary actually will give you a percentage of plaque, percentage of obstruction. So these are useful if it's going to help you. Like, I think at 47, I had a calcium score. I was like ready to go vegan if it was positive. Like, I'm going to do it again at 57. So we'll see. But I think that if it moves the needle and it helps you, then you should know what your calcium score is. Okay. I'm not going to say much about myotonic dystrophy 2, except that it's similar, but maybe later onset. And in my practice, I don't really necessarily treat it differently because I have to think about the same problems. I really treat both patients in the same way in terms of screening. All right. I want to leave a lot of time for questions. So I want to finish probably with my favorite book. And this is a strange word. Probably if you haven't read the book, you maybe have never seen the word because it's not really a word. And the reason this was chosen is because the author recognized that in all languages, there isn't a word that is the opposite of fragile, right? So any word you can think of, it's not the opposite of fragile. So you might say, wait a second, what about resilient? I think we have a talk on resilience, right? What about strong or sturdy? That's not the opposite of fragile, right? Because if you hit something that's fragile, what happens? It breaks, right? So what would be the opposite of breaking? The exact opposite of breaking. What's that? Yeah, it builds. It gets stronger. That's the true opposite, right? The opposite is that you hit it and actually grows stronger, right? Why is this such an important concept? This is more of I think is very actionable and practical. But what are we doing when we screen? We're trying to find an area of fragility and turning into a strength, right? So by catching something that is fragile and intervening at the right time, the pacemaker will work. It is now an area of strength. Your conduction system will not fail when you get the pacemaker. But you also don't want to go put pacemakers in everybody. Again, forecasting and then finding out how to strengthen systems, how to make them better. And that's really like a lot in life, right? So what about if you get a calcium score and your score comes out to be 300 and you should be closer to 100 or zero, right? You might be at an early stage of plaque. And now maybe that'll motivate you to eat a lot better. And some of that plaque will reverse because you found out that you have some calcium. So taking that area where it's fragile and actually turning it into a strength. What about if you have atrial fibrillation and it leads you to stop alcohol and saves you cancers down the line, right? And saves you all sorts of trouble down the line. You turn an area that's fragile and you've turned it into a strength. It's really what grandmas like to say, right? If it doesn't kill you, it can make you stronger. It's really ancient wisdom that's packed into this word. I think that I'll close with the last point, which is I like to use medications and devices when it's necessary, but I like to avoid them because I think our bodies have this property. They have this anti-fragile property that wants to heal and wants to try to heal, even in myotonic dystrophy, right? That's why everybody doesn't get a pacemaker. That's why the heart is not, it's weak hearts. It's not the rule, right? So the body does try to heal itself. Just take care of it and just harness it. And then we're around for a little bit when you guys need help. So that's really the talk. And hopefully that leaves lots of time for questions.
What is scarring in the heart? And is there a point at which a percentage of scarring that requires intervention?
Yeah. So scar is really an area where there's been injury. And instead of having a myocyte that is contracting, it's been replaced with extracellular tissue. That's really all it is. It's an area that used to have muscle and it's now just what you might find on keloid, for example. And the way you detect it is really with an MRI. And it can help guide some decision making in other conditions. If you see a lot of scar, it might nudge you over towards a defibrillator. We really don't know in myotonic dystrophy whether that should be the driver to make that decision. But if we extrapolate from other conditions, it can help us. So yeah, so if you're getting up into the 15% range of scar of the whole heart, that's considered high. If it's less than 5%, it's a little bit. Sure.
I know the Apple Watch and other smartwatches now have heart monitor functions. What's your general thoughts on those? And if you're a myotonic dystrophy patient and you're already getting the EKG every year, is it still worthwhile to have that Apple Watch, or is just getting your EKG once a year good enough?
I think that's a great question. I think that the Apple Watch or equivalents can be very helpful. I had it in there with a question mark for the right reasons. Some people are just obsessive and they don't want to look at it all the time. And it might not be the right thing for every patient. But I do encourage, if I see signs that I think AFib will develop, a lot of risk factors, diabetes, high blood pressure, age, the way the heart looks on the ultrasound, lots of atrial arrhythmias. And atrial arrhythmias are actually one of the things that can give you a preview that AFib might be coming. I do think that if you're at risk for it, it's a very useful tool because it's very sensitive, but sometimes not very specific. So it'll tell you you're an AFib, but then you can just take that strip, upload it to your doctor, and then says, hey, it says AFib. And then we can tell you, no, it's not AFib, or yeah, it actually does look like AFib. And then a lot of times it does change management because you're adding blood thinners, right? And AFib happens to be one of the biggest reasons why people have strokes, right? So we can prevent that. So I think it's in the right person. It makes a lot of sense. If you do happen to have a pacemaker or defibrillator, it actually has a built-in mechanism to look for that. So you just have to have your device interrogated and don't spend money on the watch. You have the ultimate. All right. Yes, sir.
Hi, two things real quick. First, if I ever saw Edward Norton playing a cardiac surgeon in a movie, he would look just like you. The second thing, my wife had AFib at one point and she almost died on the table. We went to talk to the doctor about a Watchman, and the doctor hit us with an ablation. He said, well, if I do the ablation, she won't need the Watchman, she won't need the medication. So they did the ablation and it almost killed her. And after the procedure, her heart developed a different kind of AFib. They had to take her to a special part of the hospital because there was a special medication that this part of the hospital is the only part of the hospital that was trained on how to titrate them off of this medication. And they finally got it under control, but now she's continuing to take the medication, the sotalol and the blood thinner. They said that the new AFib developed because the heart is a muscle and that's the way it reacted. But we're scared to find out if the ablation worked, because in order to do that, we'd have to stop the medication. And that was such a painful experience for my wife. My question to you would be, can you see any long-term effects from just continuing to play it safe and taking the medication, or would you recommend something else?
Yeah. Lots there in the questions. I do want to ask a lot of questions when your doctors say things that sound very dogmatic. If you do this, you won't need that, right? Because again, you have to know that we don't know everything, and that anything that's absolute, just maybe just take it with a grain of salt. Like, for example, if you do the ablation, you won't need the Watchman. The ablation is about 70% successful. Like, it doesn't work in everybody, and often you have to repeat it. So I think, so very rarely do you go do an AFib ablation and then come off blood thinners. So I think either there was they misspoke, or there was a misunderstanding somehow, but they're two separate things. Now there's a movement towards putting in Watchmans at the same time as ablation. But the reality is that the Watchman isn't better than the blood thinners. It's an alternative. And in some patients who have falls or who are prone to bleeding, it's a really good alternative, but it's not for everybody. Blood thinners work really well if you can tolerate them. So I think that for prevention of stroke, stay on the blood thinner. For AFib, I would say you have to weigh, the sotalol has its own risks, right? So you have to kind of weigh the pros and cons of using sotalol. So I think that it's too complicated to answer with the information you gave me, but I think that everything has pros and cons, and you should just know what those are in each direction, right? I think the downside of coming off sotalol, you might go back into AFib. It's usually not the end of the world, right? Usually it's not life-threatening.
If a device is needed, how do you decide between a pacemaker and a defibrillator?
Yeah, it's a great question. And I think that I don't think you'll see the same practice across the world. I'll start by saying that. You might hear different opinions from different cardiologists, but there's some obvious situations, right? So if your heart is less than, the ejection fraction is less than 35%, easy one, defibrillator. If you had an arrhythmia that's called ventricular tachycardia and you passed out, easy situation, defibrillator. Other people think that if you have a really wide QRS, right, and you're having a lot of atrial arrhythmias, maybe that's enough, even if the heart's still strong. Just err on the side of getting the defibrillator. Other people, they just don't want to be shocked. They don't have the idea, like they just, I'm not trying to grab onto every year. I just want to make sure that I want to have a pacemaker, but I don't want to be shocked. It's not for everybody. Not everybody wants to have something that resuscitates them. So I think there's some easy answers to that, and then a lot more nuanced ones. And again, sometimes the electrophysiologic study, the EP study, might guide you on one way or the other, but that's not really well studied. And I think that's more case by case.
This is a little bit related also. Do you advise patients to check if the pacemaker being offered is MRI compatible?
I mean, that's certainly a plus, right? I think that we at UCLA, we have protocols where I think just about all the devices can be put through an MRI, but I don't know if every institution is like that. But I think the newer ones are mostly MRI compatible.
Hi. So my question is more so related to, I have a link monitor, and with the link monitor, the only thing that's really seen are PVCs. So at this point in time, there's no direct link with that being myotonic dystrophy related, but I have heard a couple different things. So number one, I heard an ablation versus beta blockers. But having the information that I do have a diagnosis of myotonic dystrophy, one, the ablation you said was 70% possible.
That's for AFib.
Oh,
That's for,
AFib.
yeah, that's
Okay.
really, I'm glad you brought that up. There's
Okay.
a lot of different types of ablation.
Okay.
For PVC ablation, it's a little bit different.
Okay.
But I'll let you finish your question. But I wanted to clarify that was a AFib ablation, 70% successful.
Okay. So the reason why I asked, not because I need percentage, but they said the PVCs can always come back. PVCs can always come back, and the beta blockers have their side effects that go along with it. In that respect, is there any literature or anything that says because of the PVCs, as long as you're not breathy or symptomatic, you can continue to be with them versus how they tie with, I guess, arrhythmias and just in general, like lack of
Yeah.
a normal sinus rhythm, and how it can affect myotonic dystrophy?
No, a great question. I finished with the last point for a reason, which is just don't rush into stuff if you can avoid it, right? If the PVCs are really high burden, 30%, 35%, and your heart's getting weaker because of the PVCs and you feel terrible, there's reason to not use a beta blocker in myotonic dystrophy, right? It slows down your AV node, it slows down conduction. That would be a case where I could get my head around the PVC ablation. Your heart's getting weaker from it. It bothers you, right? It's a high burden. But I would probably say stop the Red Bulls, back off the caffeine, stop the alcohol. So there's this idea of removal is better than addition, right? Remove the things that are driving it, get better sleep, right? So PVCs are your body's way of saying, something's a little off. So just focus on doing things that might just make them get better. Take a little magnesium, right? So again, the why, right? If it's 2% PVCs, awesome. It's not that bad. It's a reassurance, right? So yeah, and again, see somebody who sees patients with myotonic dystrophy, right? That's also important, right? So someone who can say, okay, yes, you can do the PVC ablation, but should you, right? And the last thing I'll say about that is, where is the PVC? If it's in the right ventricle and they can go in there and it's really easy to find, right? Then great, easy peasy. What about if it's on the left side and they have to cross with a sharp needle over to the left side and it's at a really critical area where they might hit the aorta? Does that make sense? So where's the PVC? So there's so many layers that you really want someone to shepherd you. It's towards yes or no. Like I don't do PVC ablations, but I definitely choose when my patients get PVC ablations, right?
Hello. So my question for you today is, you got me thinking a lot when you mentioned this book about rebuilding. So if you had a 24-year-old who walked into your office, who had a heart monitor, who now you saw might need a pacemaker, is there a way to reverse it being that young? Is it just like a definite answer? Okay, yes, you need this pacemaker and defibrillator and that's it forever. And how long will it add on to your total lifespan? And is it safe to keep getting it replaced every 7 years or however much your body needs to use it?
Yeah, it's a great question. So you're right. We think long and hard before putting in devices for the reasons you're mentioning. It's not fun to go get a battery taken out. It might reassure us that your heart's not going to stop, but at the same time, you're the one going through it. And so in cases that are borderline, I just 2 weeks ago, a young patient he's in his 30s. And he's, "Doc, I didn't tell you, I've been doing weed every day. Did that affect my PR interval?" I'm like, "I don't know, but you can stop the weed and let's recheck it." And then I am sending him for an EP study, right? Because I don't want to miss an HV interval of 100. And I am giving them a chance to clean things up and say, does it get better? Because I don't know. Probably there's some mixed literature on how marijuana affects the PR interval. That's not great. But my point is that I don't know, right? But I'm not rushing him to do it. It wasn't like 280. It was just maybe 220. It's a little long, right? So I think that you want to be balanced, right? Has there been fainting episodes? If you're fainting and you can't explain it and you have a long PR and there's a family history of pacemakers at an early, a lot of things might just move you towards saying, yeah, you just got to do it. And I do think that's a situation where the device does make you stronger. It really does, because you're around to talk about it. But I'm not a big fan of scaring people into things. I think everything has a pro and a con. You weigh them out and just do the best you can with the information that you have.
First of all, thank you very much for a really excellent talk. I think everyone in the room would agree. Bill Groh was here yesterday and talked about his study from 2008, which suggested that atrial fibrillation in the absence of other structural or ischemic heart disease can be a risk factor for sudden cardiac death or ventricular arrhythmias. Going back to the question of pacemaker versus defibrillator, do you routinely put defibrillators in patients with DM1 and atrial fibrillation?
Yeah. Yeah. And I think that definitely there's a link with atrial arrhythmias as adding on and modifying the risk. So I do think that it may nudge us towards a defibrillator. A defibrillator also paces. And the downside is that you can actually get shocked inappropriately for AFib. That's the downside. So if we choose that, then we want to make sure the atrial fibrillation doesn't go so fast, because the defibrillator will shock you for fast AFib. But in myotonic dystrophy, the rates tend to be slower for AFib. That's really unusual for that to happen. So I think the upside is enough upside that I would lean towards a defibrillator in that situation, knowing what I know about atrial arrhythmias being linked with sudden death.
Did you talk about stimulants and DM1 during your talk?
I get this question a lot because I'm a cardiomyopathy specialist. So I have a lot of patients with different heart conditions. They have ADHD, right? And they want to use stimulants. And literally some people really can't function well without these stimulants. And it's a joint decision, right? We talk about it. And I think the decisions, and so sometimes we will start the medication and monitor them for a while and say, okay, we'll put a monitor on. But again, it's after really exhausting non-stimulant therapies. So I think I don't think there's an absolute answer to that. It shouldn't be 100% you can't use them. I think that's unwise. But if you can avoid them, that'd be good. That'd be great.
When you're talking about stimulants, one thing is the ADHD, but what about the use of stimulants for fatigue with dexamphetamine or modafinil? What are your thoughts about that?
I think that it's same, right? So I think that it's weighing the pros and cons. Can you have arrhythmias and higher blood pressure? Yes. Will you? Maybe not. So I'd say that if the modafinil helps you function better, have a better quality of life, and you can control the blood pressure and you're not having arrhythmias, then I'd be all in favor. Just knowing that everything has a downside. But I've seen wonderful results on some people with modafinil. So I think it's just really about recognizing that no one knows everything, and you look for the side effects, right? And if you have the side effects, then you either lower the dose or try something different. Thank you guys so much for coming today. Yeah.